Welcome everyone to this patient safety series lecture on medication reconciliation, one of the most powerful strategies for reducing the preventable medication errors and hospital readmissions, especially in geriatric patients with polypharmacy. Medication reconciliation is the systemic process of creating the most accurate and complete list of all the medications a patient is taking and comparing it against current medical orders during every transition of care. Why is it so important? Because medication errors remain one of the leading preventable causes of patient harm globally. Every time a patient is admitted, transferred, or discharged, there is a high risk of omissions, duplications, dosing errors, drug interactions, and inappropriate prescribing. The risk becomes even more greater in elderly patients experiencing polypharmacy, meaning the use of multiple medications simultaneously. Many geriatric patients take 5, 10, or even more medications daily for chronic illnesses like hypertension, diabetes, heart failure, COPD, and arthritis. Without proper medication reconciliation, dangerous outcomes can occur. Adverse drug reactions, falls, confusions, renal injury, hospital readmissions, and even mortality. In this lecture, we will explore the principles of medication reconciliation, high risk transitions of care, clinical pharmacist interventions, geriatric prescribing challenges, drug interaction screening, and evidence based protocols used to improve the patient safety. This topic is especially important for clinical pharmacists, physicians, nurses, and medical students involved in direct patient care. So let's begin understanding how simple but a structured medication review process can save lives, reducing harm and improving the healthcare outcomes. The clinical blueprint. Let's begin by understanding why medication reconciliation has become a major priority in modern healthcare systems. On the screen, we see a common real world scenario an elderly patient struggling to manage multiple medications simultaneously. This is the reality of geriatric polypharmacy. The first critical statistic is that nearly 50% of the hospital readmissions are medication related. That means half of many preventable rehospitalizations occur because of the medication errors, non adherence, duplication, incorrect dosing, adverse drug reactions, and poor transitions of care. Now, let's talk about polypharmacy. Clinically, the use of 5 or more medications is considered to be the threshold for polypharmacy. Once the patients cross this point, the risk of drug-drug interactions, prescribing cascades, falls, confusion, renal injury, and adverse events increases dramatically. This is especially dangerous in elderly patients because aging changes the body pharmacokinetics and pharmacodynamics. Drug metabolism slows, renal clearance decreases, and sensitivity to the medications become greater. The encouraging fact, however, is that around 19% of the adverse drug reactions are completely preventable. This means that structured medication review and reconciliation can directly improve the patient safety and reduce the healthcare burden. This is why medication reconciliation acts as a clinical safety command center. It allows the healthcare professionals to identify the duplicate therapies, high risk medications, incorrect dosages, drug interactions, omissions, and inappropriate prescriptions before harm occurs. For clinical pharmacists and physicians, every medication list is more than just a list of drugs. It is a blueprint of the patient's entire clinical journey. The goal is simple the right patient receiving the right medication at the right dose, through the right route at the right time, and achieving that goal begins with accurate medication reconciliation. Clinical case timeline. Now let's understand how medication reconciliation failures can rapidly lead to serious patient harm through a real clinical scenario. Meet Mrs. Savitri, a 78-year-old woman from Allahabad, EOP, who lives alone. She represents a very common high risk of geriatric patient profile, advanced age, recent hospitalization, multiple medications, and limited support at home. Let's follow her clinical timeline. On day 1, she was admitted for hip fracture surgery. The surgery itself was successful, and during hospitalization, several medications were prescribed for pain management, thromboprophylaxis, blood pressure control, gastric protection, and post-operative recovery. By day 7, she was discharged home with 5 new post-operative medications added to her existing chronic therapies. This is a critical transition of care point, one of the most dangerous moments for the medication errors. Now observe what happened next. By day 11, only 4 days after discharge, she required emergency readmission with altered consciousness and severe bradycardia. So, what likely went wrong? In many real world case scenarios, patients unintentionally continue old medication while simultaneously taking the newly prescribed ones. Duplicate beta blockers, excessive sedatives, opioid overuse, incorrect insulin dosing, or drug drug interactions can rapidly become life threatening in elderly individuals. Living alone further increases the risk because there are no caregiver for them available to monitor the medication schedules or identify the warning signs early. This case demonstrates a key principle. Hospital discharge is not the end of the treatment, it is actually one of the highest risk periods for medication related harm. Without accurate medication reconciliation, patient counseling, caregiver education, and clear discharge instructions, even a successful surgery can quickly lead to a preventable complication and readmissions. In the next slides, we will analyze how structured medication reconciliation protocols could have prevented this outcome entirely. Collision matrix. Now we arrive at the most critical point in this case study, the medication collision matrix. This slide demonstrates exactly how the medication reconciliation failures create dangerous drug duplications and interactions that rapidly become fatal in elderly patients. So, let's compare the patient's pre-admission medications list with the newly prescribed post-operative medications. First, look at the cardiovascular medications. Before admission, the patient was already taking atenolol 25 milligrams once daily for blood pressure control. After surgery, metoprolol 50 milligrams twice was added. Both drugs are beta blockers. Without identifying and discontinuing the older medication, the patient may unknowingly take both simultaneously. The result is severe bradycardia, hypertension, dizziness, syncope, and potentially life-threatening cardiac depression. This is a classic therapeutic duplication error. Next, examine the anticoagulation risk. The patient was already taking aspirin 150 milligrams once daily. Following the surgery, warfarin was newly added for the thromboprophylaxis. Now, while both the drugs may sometimes be intentionally combined under strict monitoring, failure to document indication, INR monitoring plans, and bleeding risk counseling can dramatically increase the risk of GIT bleeding, intracranial hemorrhage, and emergency readmissions. This is not merely a prescribing issue. It is a communication failure between the admission records, surgical teams, discharge summaries, pharmacists, and patients. Finally, observe the prescribing redundancy involving the pantoprazole. The medication was prescribed twice in the discharge chart. While the proton pump inhibitor duplication may appear less dangerous initially, it reveals a deeper systems level problem. Poor medication chart review, fragmented documentation, and lack of final discharge verification. Medication reconciliation is not simply about writing a list of medication, it is a structured safety process involving the verification, classification, duplication screening, interaction assessment, dose validation, and patient counseling. Every transition of care, admission, ward transfer, ICU movement, and discharge creates opportunities for the medication collisions. This slide highlights a vital clinical principle. Most severe medication errors are not caused by the rare drugs but by common medications prescribed without coordinated review. High-risk medication error categories. Medication reconciliation failures are not the random events. They follow a predictable pattern. This slide highlights the four most common categories of preventable medication errors identified during the hospital admission and discharge transitions. The first and the most dangerous category is drug interactions. Nearly 31% of medication reconciliation errors involve the missed interactions. These often occur when chronic medications are not cross-checked against the newly prescribed therapies. For example, warfarin combined with NSAIDs dramatically increases the bleeding risk. Similarly, metformin administered around contrast imaging procedures can precipitate the lactic acidosis in patients with impaired renal function. These interactions are frequently missed during the rushed admissions or fragmented discharge planning. The second category is the medication omissions. 28% of the consultation failures occurred because chronic medications are temporarily stopped during the surgery or acute illness and then never restarted. This is especially dangerous in elderly patients. Missing antihypertensives, anti-epileptics, Parkinson's medications, or insulin therapy that can rapidly destabilize a patient after discharge. Many readmissions occur not because the wrong drug was prescribed, but because an essential medication silently disappeared from the chart. Next are the therapeutic duplications. 23% of the medication errors result from duplicate prescribing. This commonly happens when multiple specialty teams independently prescribe medications from the same class without reviewing the complete medication history. Examples include 2 beta blockers, duplicate proton pump inhibitors, or overlapping anticoagulants. Duplications increase the toxicity while offering little or no additional therapeutic benefit. Finally, dose errors account for approximately 18% of reconciliation related adverse events. This is particularly critical in geriatric medicine and renal impairment. Older adults process medications differently due to reduced kidney clearance, hepatic metabolism changes and altered body composition. Standard adult doses may become toxic in elderly patients. Without dose adjustment, patient becomes vulnerable to hypertension, hypoglycemia, sedation, electrolyte imbalance, and acute kidney injury. This slide reinforces an essential patient safety principle. Medication reconciliation is not only about identifying the medicines, it is about identifying the risk. Every prescription must be evaluated for interaction, omission, duplication, and dose appropriateness. When the reconciliation is performed correctly, hospital readmissions fall, adverse drug events decrease, and patient survival improves significantly. In the next session, we will explore the structured pharmacist-led reconciliation workflow used to detect these high-risk errors before they reach the patient. The broken system versus the unified hub. Medication errors rarely occur because a single person is careless. Most errors happen because the healthcare system is fragmented. This slide compares two realities in modern hospital care: the broken silo based model and the integrated pharmacist centered safety model. Let's begin with the top section, the broken system. In many hospitals, the surgeon, ward physician, and electronic medical record system operate independently rather than collaborating. Each team focuses on its own priorities. The surgeon concentrates on procedural recovery. The ward physician manages the acute medical stabilization. The electronic medical data stores data, and it often lacks intelligent cross specialty medication alerts. As a result, critical medication decisions become disconnected. One physician may assume another team has reviewed the medication chart. Another may believe that the electronic system will automatically detect the duplications or the dangerous interactions. But the informal mental checks fail. Human memory is reliable under clinical pressure, especially in high volume wards and emergency settings. This creates dangerous care silos where the medications are prescribed, adjusted, or discontinued without full visibility across the patient's therapeutic journey. The consequences include duplicate therapies, omitted chronic medications, dose mismatches, and overlooked interactions or medications. Now look at the lower section, the unified hub. Here, the clinical pharmacist acts as the central coordination point connecting the surgeons, physicians, and the electronic medical record system. Instead of fragmented decision making, the pharmacist creates a closed loop medication safety network. The pharmacist verifies the home medications, new prescriptions, dose appropriateness, renal adjustments, drug interactions, duplications, and discharge counseling. Most importantly, the pharmacist bridges communication gap between the specialties. This transforms the medication reconciliation from a passive documentation task to an active patient safety intervention. Clinical pharmacists are uniquely trained to identify the hidden prescribing risks that may be overlooked during the busy clinical flows. Studies repeatedly showed that the pharmacist led consultation programs include the hospital's readministration, adverse drug events, medication dispenses, and mortality in high risk elderly populations. It can be reduced. So, this slide highlights a powerful modern healthcare principle. Technology alone cannot prevent medication errors. Safe prescribing requires coordinated human oversight, structured communication, and interdisciplinary collaboration. And at the center of the safety ecosystem stands the clinical pharmacist. The Match Reconciliation Protocol. Now let's examine one of the most effective structured frameworks used in the modern medication reconciliation, the Match Protocol. Match is a stepwise patient safety model designed to reduce the medication discrepancies during the transitions of care. Each letter represents a critical phase in the conciliation process. Let's begin with the first step. M is for medications. This stage focuses on collecting the best possible medication history, commonly known as BPMH. Importantly, the medication list should never rely on a single source alone. Information must be verified from at least two independent sources, such as patient interviews, prescription records, family members, pill bottles, previous discharge summaries, or pharmacy refill data. The goal is accuracy before prescribing any decisions that should be taken. Next comes A. Assess. Here, the pharmacist or the healthcare team compares the patient's chronic medications with the current hospital prescriptions. This is where clinicians actively search for drug duplications, dangerous interactions, dose mismatches, omissions, and inappropriate medications according to the Beers criteria in the elderly patients. Assessment transforms a simple medication list into a clinical risk evaluation tool. The third step is T. Translate. This phase covers and converts multiple fragmented medication orders into one unified discharge medication plan. Patients should never leave the hospital with separate surgical, cardiological, and medical specialty lists that contraindicate each other. The medication plan must be simplified, harmonized, and clinically coherent. This greatly reduces the confusion, especially in the geriatric patients with polypharmacy. The fourth step is C. Communicate. Even the most accurate medication plans fail if the communication fails. Clear handovers must be provided to the primary care physicians, community pharmacists, caregivers, and most importantly, the patient. Instructions should be explained in simple language, in patient's local language, with explicit clarification of what changed, what stopped, what started, and why. And finally, H. Handoff. Medication reconciliation does not end at discharge. A proper handoff includes post discharge follow up, often within 30 days, to evaluate medication adherence, side effects, confusion, and the therapeutic outcomes. This closely looks at the safety loop and identifies the problem before they lead to readmission. The match framework demonstrates a fundamental healthcare principle. Medication safety is a continuous process, not a single event. Every transition point creates potential for harm, and every step of reconciliation creates an opportunity for prevention. When implemented correctly, structured reconciliation protocols significantly reduce the adverse drug reactions, emergency readmissions, and preventable mortality in vulnerable patients. AGS Beers Criteria 2023. High risk drugs in older adults. Elderly patients are uniquely vulnerable to medication related harm. Age related physiological changes alter how drugs are absorbed, distributed, metabolized, and eliminated. This is why geriatric pharmacotherapy requires special caution. To address this challenge, the American Geriatric Society developed the Beers Criteria, one of the most important medication safety guidelines in the modern clinical practice. This slide summarizes key risk high medications identified in the 2023 AGS Beers Criteria for adults aged 65 years and older. Let's begin with always avoid category. First are benzodiazepines such as alprazolam and diazepam. Although commonly prescribed for anxiety and insomnia, these drugs significantly increase the risk of falls, fractures, sedation, confusion, and dependence in elderly patients. Even low doses may impair cognition and mobility. Next are the anticholinergic medications, including drugs like oxybutynin. These are medications that can trigger delirium, urinary retention, constipation, blood vision, and severe cognitive decline. Older adults are especially sensitive to anticholinergic burden, particularly those with dementia or frailty. Now observe the digoxin. Doses above 0.1 to 5 milligrams per day are considered high risk in many elderly patients due to reduced renal clearance and increased susceptibility to toxicity. Symptoms may include arrhythmias, visual disturbances, nausea, and confusion. Another major concern involves the first generation antihistamines, such as the promethazine. These agents cause profound central nervous system depression, sedation, and delirium, especially in hospitalized geriatric patients. Now let's move on to caution category. Long-acting sulfonylureas, particularly some of them can produce prolonged and potentially fatal hypoglycemia in elderly individuals. Because older adults often have inconsistent meal intake and impaired renal function, these agents require extreme caution or avoidance. Finally, look at the avoid in condition section. NSAIDs may appear harmless because they are commonly used, but in patients with chronic kidney disease, heart failure, or gastrointestinal vulnerability, they can precipitate GI bleeding, fluid retention, acute kidney injury, and worsening heart failure. This slide highlights a crucial medication safety principle. A drug that is inappropriate or appropriate for a younger adult may become dangerous in the elderly patient. Medication reconciliation must therefore include or not only for the drug verification but for the geriatric appropriateness screening. The BS criteria acts as a clinical safety filter, helping the healthcare professionals identifying the medications that increase the risk of hospitalizations, falls, cognitive decline, and mortality in older adults. Stop and start criteria in the geriatric prescribing. Medication safety in older adults is not only about identifying the harmful drugs, it is also about recognizing when important therapies are missing. That is the foundation of STOPP and START criteria, two powerful clinical tools used in the geriatric pharmacotherapy. Let's begin with the STOPP, which stands for Screening Tool of Older Person's Prescription. The STOPP criteria helps the clinicians identify the medications that may be inappropriate, unnecessary, or potentially harmful in elderly patients. The first example shown here is aspirin without established cardiovascular disease. In older adults, routine aspirin use without clear cardiovascular indication may expose patients to bleeding risk without meaningful benefit. Next, observe the prolonged PPI use, proton pump inhibitor use. PPIs used beyond 8 weeks without a valid indication can increase the risk of osteoporosis, fractures, vitamin deficiencies, and Clostridium difficile infection. Many elderly patients continue PPIs for years without reassessment. Another important STOP example involves the calcium channel blockers in patients with chronic constipation. These drugs can worsen the bowel motility problems, leading to the discomfort, fecal impaction, and hospitalization in frail elderly individuals. Finally, the tricyclic antidepressants should generally be avoided in patients prone to falls. These medications cause sedation orthostatic hypotension, and anticholinergic effects, dramatically increasing the fall and fracture risk. Now let's move to the right side, the STAT criteria. STAT stands for Screening Tool to Alert to Right Treatment. Until STOPP, the STAT framework identifies the beneficial medications that are often omitted in elderly patients. For example, statins should be considered in patients with established cardiovascular disease who have a reasonable life expectancy. Omission of avoidance and the evidence based cardioprotective therapy may worsen long term outcomes. Next, biphosphonates are recommended in early and elderly osteoporotic patients receiving long term corticosteroids because steroids significantly accelerate the bone loss and fracture risk. Vitamin D supplementation is another important intervention, particularly in homebound, frail, or fall prone elderly individuals. Adequate vitamin D improves the bone health, muscle strength, and fall prevention. Finally, the ACE inhibitors or ARBs are essential therapies in heart failure patients unless contraindicated. Failure to prescribe these medications can lead to worsening cardiac remodeling, hospitalization, and increased mortality. This slide demonstrates a critical principle in geriatric medicine. Appropriate prescribing is a balance between the deprescribing harmful therapies and initiating the beneficial ones. Good medication reconciliation is not simply about reducing the medication numbers, it is about optimizing the therapy for safety, function, quality of life, and survival. The STOPP and the STAT frameworks help the healthcare professionals move from reactive prescribing to evidence based, individualized geriatric care. Medication reconciliation. So, it is not a one time activity, it is a continuous safety process that must occur at every major transition of care. This slide outlines a structured 5 step workflow designed to reduce the medication errors, prevent the ADRs, and lower the hospital readmission rates. Let's walk through the process step by step. Step 1 begins at admission, ideally within the first 24 hours. At this stage, the clinical pharmacist collects the best possible medication history, commonly called the BPMH. This information should be gathered from at least two reliable sources such as the patient, family members, previous prescriptions, community pharmacist, or old medical records. The medication list is then documented accurately in the electronic medical record system. The first step is critical because the inaccurate admission histories often lead to cascading prescribing errors later during the hospitalization. Step 2 occurs during the specialty consultations. Before any specialist adds, changes, or discontinues the medications, the BPMH must be reviewed carefully. This prevents the duplicate therapies, drug interactions, and omission of essential chronic medication. For example, a cardiologist, surgeon, and a physician may each prescribe medications independently, creating unintended therapeutic overlap. The pharmacist acts as a central safety checkpoint in this process. Step 3 focuses on the ICU and ward transfers. Transitions between the departments are among the highest risk periods for medication discrepancies. At this point, the medication list must be re-verified, drug allergies should be updated, renal function should be reassessed, and dose adjustments should be reviewed carefully. Critically ill patients frequently experience rapid physiological changes, making dosage reassessment essential. This stage prevents toxicity, underdosing, and inappropriate continuation of temporary therapies. Step 4 happens before discharge, preferably more than 24 hours prior. This is the final reconciliation point. The pharmacist performs a complete review such as the Beers Criteria, STOPP START criteria, and renal dosing guidelines. He uses the tool. A single unified medication list is created to avoid the confusion from multiple specialty prescription. Equally important, the medication plan must be explained and planned clearly to the patient and caregivers in their local language. Patients should understand which medications to continue, which to stop, and why each drug is necessary. Effective counseling significantly improves the adherence and reduces the post discharge complications. Finally, step 5 involves the follow up after discharge. Typically, around 7 days. This may occur through telephone consultation, telemedicine, or outpatient follow up. The purpose is to assess the side effects, adherence, clinical response, and any new medication related concerns. The final step closes the communication loop between the hospital teams, primary care physicians, and patients. Many medications related readmissions occur because problems after discharge go unnoticed until they become emergencies. This workflow demonstrates that medication reconciliation is not simply paperwork, it is a longitudinal patient safety strategy that requires the coordination, verification, communication, and follow up across the entire healthcare journey. When implemented properly, this process can dramatically reduce the preventable harm, especially in elderly patients with polypharmacy. Now let's apply everything we have learned to a real world clinical scenario. A 75-year-old male patient is admitted for elective knee replacement surgery. His chronic medications include warfarin, metformin, atenolol, and aspirin. Following the surgery, he is started on enoxaparin for thromboprophylaxis and naproxen for pain management. By postoperative day 4, the patient develops a GIT bleed. The question is, what is the most likely cause? The correct answer is drug interaction caused by failure of medication reconciliation. Let's analyze why. This patient was already taking aspirin and warfarin before the admission. Postoperatively, high-risk medications were introduced. Enoxaparin, which is another anticoagulant, and naproxen, an NSAID known to increase the GIT bleeding risk. When aspirin, warfarin, and enoxaparin are combined, the patient experiences additive anticoagulant and antiplatelet effects. Adding naproxen further damages the gastric mucosa and impairs the platelet function. Together, this creates a perfect storm for severe GI bleeding. Importantly, this adverse event was preventable. A proper medication reconciliation process at admission should have been identified. Existing anticoagulant therapy, high risk bleeding and the patient's advantaged, which independently increases the bleeding risk. This case demonstrates why medication reconciliation is far more than administrative documentation. It is a life saving clinical intervention. Let's briefly examine the incorrect options. Option A, surgical trauma, may contribute to the mild postoperative bleeding, but it does not explain delayed GIT hemorrhage occurring on day 4. Option C, metformin induced GI bleed, is incorrect because metformin commonly causes GIT upset such as nausea or diarrhea, but not significant GI bleeding. Option D, enoxaparin overdose, could theoretically cause bleeding, but there is no evidence of dosing error here. The much more likely explanation is the dangerous drug combination itself. This scenario highlights several important principles. First, elderly patients with polypharmacy are extremely vulnerable to adverse drug events. Second, high-risk drugs such as anticoagulants, NSAIDs, and antiplatelets require meticulous review during transitions of care. And third, clinical pharmacists play a crucial role in identifying these interactions before harm occurs. This slide also highlights an important healthcare systems issue. Only a small proportion of tertiary hospitals currently implement the structured medication reconciliation protocols consistently. Strengthening these systems can dramatically reduce the preventable morbidity and mortality, also the hospital readmissions. This case is a reminder that many medication-related complications are not due to rare diseases. They are due to communication failures and missed safety checks. One accurate medication review could prevent an entire cascade of harm. Patient counseling framework and medication reconciliation. Medication reconciliation does not end with creating an accurate medication list. The final and the most important step is ensuring that the patient truly understands their therapy. This slide highlights 5 essential counseling questions every healthcare professional should discuss before discharge. The questions improve the adherence, prevent medication errors, and empower the patients to participate actively in their own care. Let's go through each component. First, purpose. Patients should clearly understand what does each medicine do for me. When patients know why a medication is prescribed, they are less likely to stop taking it on their own. For example, a patient may discontinue antihypertensive medication simply because they feel fine. without realizing that the drug is preventing their silent complications like stroke or heart failure. Explaining the purpose of the therapy significantly improves the long term adherence. Second, omissions. Patients must ask, are there any medicines I should stop? During hospitalization, certain chronic medications may be started due to surgery, renal impairment, or acute illness. If these drugs are not restarted, serious complications can occur after discharge. Next, this step helps identify the hospital held medications and prevent accidental discontinuation of essential therapies. Third, monitoring. Patients should understand what side effects should I watch for. Early recognition of adverse drug reactions can prevent emergencies. For example, patients on anticoagulants should recognize warning signs such as black stools, unusual bruising, or bleeding. Patients taking diuretic should know symptoms of dehydration or electrolyte imbalance. Clear counseling transforms patient into safety partners. Fourth, interactions. Patients should ask, can I take this with my other medicine? This question is critical because many patients also use OTC medications, herbal products, or traditional remedies without informing their healthcare providers. For example, NSAIDs combined with the anticoagulants greatly increase the risk of bleeding. Certain herbal supplements may interfere with cardiac drugs or diabetic medications. Medication reconciliation must therefore include prescription, OTC, and herbal therapies together. And finally, the escalation. Patients need clear instructions about who should I call if something seems wrong. Many adverse events worsen simply because the patients delay seeking help. Providing emergency contact information, follow up instructions, and clear warning signs can prevent the dangerous delays in the treatment. This step is especially important for elderly patients living alone or those with limited healthcare access. Overall, this counseling framework transforms discharge from a passive event into an active patient safety intervention. The goal is not only to prescribe the medications but to ensure that the patient understands, remembers, and safely follows the treatment plan. Effective counseling reduces the readmissions, improves adherence, and strengthens trust between the patients and the healthcare professionals. In medication reconciliation, communication is just as important as pharmacology. Medication reconciliation, the most important in Pharmacist discharge checklist for geriatric patients. As we approach the final stage of medication reconciliation, this slide presents one of the most practical tools in patient safety, the Pharmacist discharge checklist. For geriatric patients with polypharmacy, discharge is one of the highest risk moments in healthcare. A single missed instruction, duplicate prescription, or unrecognized interaction can lead to serious complications, emergency readmission, or even death. This checklist ensures that no critical step is overlooked and before the patient leaves hospital, the patient understands everything. Let's review each component carefully. First, a unified medication list must be provided. Patients should receive only one complete medication list, not separate lists from different specialists. Fragmented discharge instructions create and dramatically increase the medication errors. A single reconcile list improves the clarity, adherence, and continuity of care. Second, all the new medications must be explained clearly. Patients should understand the indication, dose, timing, and duration of every newly prescribed drug. This is especially important in elderly patients who may already be managing multiple chronic therapies. Without proper counseling, patients may accidentally omit, duplicate, or misuse the medications. Third one. So, all the discontinued hospital medications must be clarified. Temporary in hospital medications such as injectables, anticoagulants, IV antibiotics, or perioperative analgesics should not be continued unintentionally after discharge. Equally important, chronic medications that were held temporary must either be restarted appropriately or documented clearly if discontinued. Drug interactions must be reviewed and flagged. This includes the prescription drugs, OTC medications and herbal supplements. Many patients do not realize the common OTC drugs like NSAIDs, antacids, or herbal products that can interact dangerously with the anticoagulants, cardiac medications, or diabetes therapies. This interaction review is a key role of clinical pharmacist. Fifth, the Beers Criteria and STOPP screening review should be documented. These tools help the healthcare professionals to identify potentially inappropriate medications in elderly patients. Reducing high risk medication lowers the risk of falls, delirium, hypoglycemia, renal injury, and hospital readmission. Next, a referral letter must be sent to the general practitioner or primary care physician. Medication reconciliation is only effective when the continuity of the care is maintained after the discharge. Clear communication between hospital teams and outpatients prevents therapy duplication and confusion. The checklist also includes scheduling follow-up calls at 7 days and 30 days after discharge. These follow-ups help assess the medication adherence, side effects, clinical progress, and new concerns. Many complications occur after patients return home, making the follow-up an essential extension of the reconciliation process. Finally, patients must receive clear emergency instructions. They should know exactly when to seek urgent medical attention. Examples include bleeding, altered consciousness, chest pain, severe vomiting, or sudden worsening symptoms. Providing these signs reduces dangerous delays in the care. Overall, this checklist transforms discharge from a routine administrative task into a structured patient safety intervention. It demonstrates how clinical pharmacists play a central role in preventing medication related harm, especially in vulnerable elderly population. In modern healthcare, safe discharge planning is just as important as successful treatment inside the hospital. Now, as we conclude this discussion on medication reconciliation, remember one important truth. Every medication list tells a story. Behind every medication or prescription is a patient, a diagnosis, a risk, and a responsibility. But without proper reconciliation, the story becomes fragmented, and fragmentation in healthcare can lead to preventable harm. In geriatric patients with polypharmacy, even a single missed interaction, duplicate therapy, or omitted medication can trigger serious consequences, hospital readmission, or organ damage, falls, bleeding, delirium, or even death. Medication reconciliation is therefore just not paperwork, it is a clinical safety intervention. It is a communication, coordination, verification, and continuity of care combined into one process. Throughout this presentation, we explored how structured reconciliation protocols help identify the drug interactions, prescribing omissions, dose errors, duplicate therapies, and potentially inappropriate medications. We also saw how tools such as the match protocol, Beers criteria, stop start screening, and pharmacist led discharge planning can dramatically improve the patient's outcome. Most importantly, we have learned that medication safety does not end at discharge. Follow up, patient counseling, clear communication, and interdisciplinary collaboration are essential to close the loop. Every drug list has a story only reconciliation can read. When healthcare professionals carefully review and reconcile the medications, they are not just comparing the list, they are protecting the lives. For pharmacists, physicians, nurses, and healthcare students, this responsibility is one of the most powerful ways to reduce preventable harm in clinical practice. So, document carefully, communicate clearly, follow up consistently, and always treat every medication list as a critical clinical document, not an administrative form. Thank you for watching this presentation on medication reconciliation protocols for reducing the readmission rates in geriatric polypharmacy. Thank you for staying till the end of this presentation. I hope this session helped you understand the critical role of medication reconciliation in preventing adverse drug events, reducing the hospital readmissions, and improving the patient safety, especially in elderly patients with polypharmacy. As future healthcare professionals, clinical pharmacists, physicians, or medical students, remember that even one accurate medication review can save a life. Small interventions like identifying a drug interaction, preventing a duplication, or counseling a patient correctly can create a major impact on clinical outcomes. If you found this presentation valuable, please like, share, and subscribe to support more educational medical content. Feel free to comment your thoughts, clinical experiences, or topics that would you like to get covered in upcoming videos. Thank you once again for watching, and I'll see you in the next session.